Recording in progress.
And of course, your participation is your consent to allow the recording of your voice if you say anything. So Janine Logan, VP of Communications and Population Health for the Nassau Suffolk Hospital Council, which oversees the Long Island Health Collaborative, and I also direct the Long Island Health Collaborative. So are we gonna?
Speaking of that packed agenda, it is up there just for your reference.
Oh, yeah,
just
that's
if you
the
wanted to
agenda.
take a
Okay,
look.
so we're gonna introduce, we're gonna go really quick around the room and around the Zoom room. Just your name and your organization, but before we do that, I'd like to introduce our intern who's with us, Alexis Sisso.
Good morning, everybody.
And she's working directly, she's working directly with Brooke, and she's fantastic, and we're happy to have her here. And I understand she was very excited about this meeting, so we'll ask her after if it turned out to be so. So welcome, Alexis, and maybe we'll start with you, Grace.
Okay, Grace Kelly McGovern, Suffolk County Department of Health Services.
Maddie McTullian, Horizons Counseling and Education Center.
Kelly DeVito, Horizons Council and Education Center.
Nadine Wilches, CEO of My Dark Health.
Cynthia Ngombe, healthcare advocate for Long Island Healthcare Education Project, 1199.
I'm Brooke Oliveri. I manage the Long Island Health Collaborative.
Melissa Zizzo, I am Brooke's intern.
I'm Francesca Dam. I am the program director for Nassau Suffolk Hospital Council.
I'm Deshaun Walters, and I work for PBMC as a community outreach specialist.
I'm Patrick Hannes, and I'm community outreach for PBMC also.
Danielle Craig, Suffolk County Department of Health, Chartship and Compliance and Credentialing.
Cliff Document with the Revmont Group, representing Care Kids.
Yeah, nice to meet you all.
Thank you.
So you want to hold a roll call on the?
And I just want to do a quick check. On Zoom, can you all hear us? Can I get a thumbs up? Okay, I just, I know Lori, I see you cannot hear us. I'm sorry about that. Maybe if you increase your volume, let us know if the problem continues. Lori, can you hear us? Okay, so let's go around the room on Zoom. Maria, are you there to introduce yourself? I know Maria is dealing with some stuff this morning, so maybe we'll move on to Galal.
Guys, it's Maria. I'm on the phone with the doctors. But it's Maria McHugh from Stony Brook Children's.
Thank you.
You're welcome.
Okay. Galal?
Good morning. Galal Arzokum, Director of Case Management at Belgaram Psychiatric Center.
Thank you.
Hi, Rajiv, is it?
Rajiv?
Yes, good morning. Rajiv Lajmi, Chair of the Health Informatics Program at Stony Brook University.
Oh, good. Thank you. Lori?
Good morning, Lori Andrade, Health and Welfare Council of Long Island.
Thank you. Analia?
Good morning, everyone. I'm Analia Trask. I'm a program coordinator for the Cancer Prevention and Action Grant Program at Stony Brook Cancer Center's Office of Community Outreach and Engagement. Thank you.
Thank you. Kali?
Good morning, Kali Chan, Director of Medicine Media Relations at Stony Brook Medicine.
Thank you. Dr. Mermelstein?
Hi, Linda Mermelstein. I'm the Associate Director for Community Outreach and Engagement at Stony Brook Cancer Center.
Thank you so much. Lucy?
Hi, good morning. I'm Lucy Miller. I'm a Community Programs Manager for the Community Engagement and Health Equity Team at Memorial Sloan Kettering.
Thank you. Christine?
Hello, I'm Christine Duffy. I'm a project manager from St. Mary's Healthcare System for Children.
Thank you. Adesola?
Good morning, Adesola Watson, Director of the Office of Minority Health and the Suffolk County Department of Health Services.
Thank you. Zareen?
Good morning. Zareen Bajwa with Cornell Cooperative Extension. I'm the Director of Community Program.
Thank you. Christina?
Good morning, Christina Nadolny. I work with Zareen from Cornell Cooperative Extension of Suffolk County.
Thank you for joining us. Lori Harris?
Hi, can you hear me? I hope. My name
Yes.
is Okay, great. I was having a little trouble there. My name's Lori. I'm with HealthX. We're a health information exchange, and I'm a customer engagement partner.
Thank you. Colleen?
Hi, I'm Colleen McVeigh. I'm the lead strategist for the 1115 waiver at HANYS.
We're excited to hear from you in
Yes,
just a
we
few
are.
minutes. Laura Callan?
Hi, everybody. I'm the Director of Peer Workforce Development at Hands Across Long Island.
Thank you. Melissa Bauer?
Hi, I'm Melissa Bauer from HANYS DataGen. I'm the data analyst.
We'll hear from Melissa in a little bit too. Gary Carpenter? Maybe we will come back to Gary. Jack Schneerman?
Good morning. I'm Jack Schneerman. I am Vice President of Strategy and Community Population Health at Northwell Health, and I am coordinating our 1115 waiver work. Apologize for not being on camera. I'm in transit this morning.
No worries. Okay. Thanks for joining us. And Cynthia Friedman. Oh, we cannot hear you, Cynthia. I'm sorry. Oh, we see it in the chat. Director of Public Health for Suffolk County. Okay, thank you for letting us know.
Mic isn't okay.
And I do see Gary unmuted. If you'd like to introduce yourself.
Yes, good morning. Can you hear me now?
Yes, we can.
I'm Gary Carpenter, president of Gary Carpenter and Associates, Inc. We are a management consulting firm representing home health throughout the state of New York.
Thank you.
Thank you. So welcome, everyone. Good crowd here, always a diverse group. We are going to move right to here to Colleen McVeigh, who is Senior Healthcare Informatics Analyst at the Healthcare Association of New York State, of which Nassau Suffolk Hospital Council is a part. And Colleen is the 1115 waiver guru and knows, I don't want to say everything, but pretty much everything about what's going on with the waiver on a kind of a global state level. And then we will hear later on from Lori on, Lori, I don't pronounce your last name correctly. It's Andrade, who is going to talk about the social care network and the application and the efforts of Health and Welfare Council in that regard. So we'll turn it over to Colleen, and I guess we'll take questions after, I think, Colleen, after you go through, unless there's something very confusing or startling, we can stop. So
Absolutely, whatever your preference is. So, all right, can everybody see the correct slide? You're not seeing a notes page or anything like that?
Yes.
Okay, perfect. All right, so I'm Colleen McVeigh. I'm from HANYS, and I've recently been tapped to be the lead strategist here regarding the 1115 waiver. So just a quick overview on the actual waiver and what it's going to look like overall. We received approval the first week of January of this year, and that approval is going to go through the end of March 31st, 2027. So that's basically, a 3-year waiver or less at this point. Typically, you would see an 1115 waiver be anywhere from 3 to 5 years. And this was originally a 3.5-year waiver, maybe even a 4-year waiver. However, that clock started ticking quite some time ago. So basically last August. So we are in a very shortened time frame to achieve the goals of the waiver. We're looking at approximately $7 billion. And the initiatives are broken up into 3 different goals. So we're going to be looking at the health-related social needs infrastructure and services, strengthening the workforce, and several population health initiatives. So this is a summary of what the funding is going to look like, broken down by initiative, by goal, and also as a percentage of the total funding. So this gives you an idea of where New York State's priorities really are with this waiver, where they're putting the money. And over 50% of the total funding is directed towards health-related social needs. The bulk of that is going directly to paying for newly authorized reimbursable health-related social needs services. But there's also a significant amount of portion of that funding that is going to be set aside to develop the health-related social needs infrastructure, which obviously Lori is going to be covering in much more detail than I will. As far as strengthening the workforce, there's about 10% of the total budget going towards that across 2 different programs. And I will get into that in a little bit. And then there's several population health initiatives. Some we know a little bit more about than others. However, the biggest part of that is about 30% of the total budget will be going towards a Medicaid Global Budget Initiative, which I will discuss. So let's go and get started. Diving right into the health-related social needs, there's going to be $500 million, which is going to go towards establishing the social care networks. Those networks are going to be responsible for not only screening and referrals as well as case management, but also developing those networks of providers that are going to be providing those services. They will be acting as an intermediary, between those service providers and the Medicaid managed care delivery system. As far as funding, and the regions and how that's going to be allocated, you can see here that there's going to be 9 regions. One of those is New York City, which could potentially be up to 5 different social care networks. The application for this is due beginning of April, with a target award date of June and a start date, of building those networks between August and, hopefully in August of this year, with services starting early next year. Applicants can apply for multiple regions, so we may not have anywhere between 9 and 13 unique entities. However, somewhere in that neighborhood. This is what the social care network ecosystem looks like, or might look like, according to Department of Health. Again, I'm pretty sure that Lori will be able to cover this in much more expertise than I will, as I've spoken with her before, and she's very knowledgeable about this area. But coming from HANYS, I did want to just highlight, how hospitals and hospital systems might be expected to interact within this ecosystem. And essentially, DOH sees the hospitals as not only delivering, our normal services to Medicaid members, but also contracting with social care networks. They see them acting within the care network and the IT platform that care network chooses. To help with social care navigation, to provide screenings, validating eligibility, things like that. So DOH is strongly recommending that hospital systems, start looking at, who the likely partners are in their area and engaging with them. So what are those services going to look like, these new services? So there's going to be a level 1 and a level 2. Level 1 is going to be the existing programs that already exist within the state, and those will be eligible for all current Medicaid beneficiaries, and also health screening. And then those level 2 services are going to be available for certain targeted populations. So high utilizers, health home enrollees, you can see that list on the right. And the services themselves will be broken down into 4 different areas in addition to the screening. So this is just a quick overview of what those services might look like. We're looking at, for housing, something that I was particularly interested in was like home remediation and home accessibility modifications. So this is a way to keep individuals in their homes safely for a longer period of time. So that could be things like mold remediation or, accessibility modifications like ramps, things like that. Various different nutrition programs, transportation programs, case management, things like that. So the next big component for HANYS that we're watching closely and for our hospitals is strengthening the workforce. Obviously, I don't need to tell anybody in this room that this is a struggle for healthcare across New York State and particularly hospitals. So this just gives you an overview of what this section is going to look like. Oh, hello. So there's going to be a total of $694 million allotted for this program. And then it's going to be broken up into two different programs, a career pathways training and a student loan repayment program. And then the career pathways training is then again broken down into two different categories, which I'll talk about in just a second. So for the student loan repayment for qualified providers, this is going to be obviously a student loan repayment program. New York State will select eligible individuals. So those are going to be individuals who are working in very specific shortage professions. So psychiatrists, primary care physicians, etc. You can see the list here on the slide. Pardon me. And then those individuals have to make a 4-year commitment to a practice panel with greater than or equal to 30% Medicaid or uninsured populations. So we are targeting safety net providers here. And then the Career Pathways Training Program is going to fund training and education for two different tracks of individuals. There's going to be a track for career advancement and then a track for unemployed individuals who are breaking into the healthcare field. These individuals will all need to make a 3-year commitment to that same practice panel criteria. These are going to be administered by the workforce investment organizations, which some of you might remember from the last 1115 waiver from DSRIP. There's going to be 3 regions throughout the state. One will be one for each WIO, essentially. And then titles here are related to nursing, professional and technical roles, as well as frontline public health worker titles. So jumping into the population health element, the first thing that we're going to be seeing is a health equity regional organization, or a HERO. This entity is going to be responsible for overseeing basically all of the program activities. They're going to be responsible for aggregating data that's received from the social care networks, analyzing it, and then reporting on it. They're going to be performing needs assessments and regional planning. They're going to be responsible for convening stakeholders, as well as making VBP recommendations and conducting overall program analysis. So this is going to be a very big job. We don't know who this is yet, although DOH is looking at several specific entities that are very independent of New York State health, healthcare providers as much as possible. And that is not only a goal of New York State Department of Health, but also a requirement of CMS. So this is going to be the biggest part of this population health initiative, and arguably one of the more exciting or maybe even trepidatious programs, and that is going to be a global budget initiative. Now, this is there's a little bit of nuance here. The global budget is part of the waiver, but also separate. So the waiver piece of the global budget is actually going to be this $2.2 billion incentive fund. And this fund is going to support very specific financially distressed hospitals, safety net hospitals, in their journey to transitioning to a global budget. So this is not only to support them financially, but also incentivize hospitals to join on to this program because it is voluntary. So this is going to help these hospitals focus on population health and health equity and stabilizing their hospital finances. That being said, the way this is probably going to work is the downstate region is going to apply for the CMMI AHEAD model. So that's advancing health equity and development. So advancing health equity and approaches and development, or the AHEAD model, and that's coming out of CMMI. I just realized that I hadn't put out the full thing on this slide. So as long as New York State is accepted into the AHEAD model, which is not a guarantee, then this program will encompass the Medicaid Global Budget Initiative in its entirety. If for some reason this region is not selected, then the state will need to submit its own model, which will end up likely looking very similar anyway. So what is a global budget? Global budgets are an alternative payment model that will essentially pay hospitals a upfront predetermined amount of money based on services provided to a specific population over a given time frame. So we're going to, look back at what a hospital has spent on a given population, and then we're going to adjust it a little bit and pay them every 2 weeks throughout a year in order to provide those services to that population in the future. So this is going to shift risk from payers to hospitals. It's going to constrain healthcare cost growth and hopefully incentivize value-based care. The waiver does incentivize those specific hospitals in specific areas of New York to accept that global budget. And that's what this will probably look like. So in order to receive that $2.2 billion, those hospitals have to be private, not-for-profit hospitals in Bronx, Kings, Queens, and Westchester counties. And they have to have a Medicaid and uninsured payer mix of more than 40%. They have to have an average operating margin that is less than or equal to 0 over the past 4 calendar years. And then they also have to have been receiving state-only subsidies due to financial distress in 2023 and or 2024. So that's going to be basically VAPAP, or other state subsidies. We estimate that that's going to be somewhere between 12 and 13 hospitals. Now, that does not mean that other hospitals in the downstate region, although we're not quite sure what the totality of that region might be, it doesn't mean that other hospitals can't participate in the AHEAD model. DOH is still working on those details, and there is more to come on that. So what is the AHEAD model going to look like? So there's going to be 3 main components. There's going to be a cooperative funding agreement. So this is going to be like an initial setup period where CMS will give funds to the hospitals who are participating so that they can begin planning activities in order to establish themselves for their first measurement year. The hospital global budget, obviously, I've discussed, that's going to provide that fixed amount of revenue for the upcoming year for hospitals. That is going to be an all-payer global budget. So we're going to be looking at a Medicare fee for service, a Medicaid, and a commercial payer hospital global budget. In order to be chosen for AHEAD, DOH does have to commit to bringing on at least 1 commercial payer. And then there's also going to be a primary care component here. So the primary care model is actually going to align with the Medicaid Making Care Primary, which will be the upstate essential version of this primary care investment within the waiver. So this is what the AHEAD timeline is going to look like. New York State will be applying for the 3rd cohort for the AHEAD model. So that means that applications are going to be due at the beginning of August of this year. That will put the pre-implementation period for this program squarely in the 2025 to 2026 time period. And then in 2027, that would be the first actual payment year for the AHEAD model for those hospitals who choose to join. And I did want to stress that this is a voluntary model. It is separate from the waiver, so other hospitals can potentially join. We're just not sure what the actual regional boundaries might look like. And that's going to be a decision not only from DOH, but also what CMS will agree to. So with that, I'll stop and I will see if anybody has any questions or anything they'd like me to go over in more detail.
So feel free to unmute if you're joining us virtually, or if you'd like to put your question in the chat. Thank you so much, Colleen. That is all, I always learn
Absolutely.
something new when you present, even though I've listened a few different times, so.
She really,
One question, could she go back to the last slide so I can get the info? It was very, sorry.
I'm sorry, the ahead timeline?
No.
Was that what you?
The contact info
oh,
on it.
we're gonna be sending these slides out.
Oh,
to
thank
everybody,
God. I've been
so
taking
you don't have
pictures.
to
Oh,
worry.
yes, I'm so sorry. Yes, I will send these slides out for you.
Yeah.
No
Everybody
problem.
get the slides and,
Yes.
and the recording too, right?
Yes,
And
yep, this whole meeting is being recorded.
we always share that. We don't have any questions in the
No
chat.
questions in the chat right now, no.
I have, well, I have to ask a question.
You are, yes.
Colleen,
yes.
First of all, you did a fantastic job, and you always do. I'm a little confused about the ahead model and this, like you said, it's separate, but then you also said there was a part where it had to be connected to the global budget. Can you just like maybe run through that again? I mean, I don't know if I caught it.
Sure. Yeah, no, it's a pretty heavy nuance there that,
Yeah.
That we're still trying to navigate. So the waiver, the only global budget initiative within the waiver is that incentive funding. That's it. However, the ahead model can be is going to be applied for a specific region. So essentially the downstate region. We're just not sure specifically what counties. It's definitely going to be those 4, and then potentially maybe Long Island. In addition to that, we're not sure yet. That's going to be a negotiated situation between CMS and DOH. Any hospital within that can participate, should they decide to do so. There are, ups and downs to participating in a global budget. Obviously, it's a really big risk for hospitals. A lot of hospitals are kind of on the fence about whether or not it's going to be a good idea for them. A lot of safety nets are feeling like this might be a savior. This might be a good way to, financially stabilize the New York State safety net. Others obviously are very concerned over the risk, particularly workforce would be an issue downstate. These are hospitals that have to negotiate labor contracts pretty frequently, and global budgets can't always take that into account. So yeah, there's definitely going to be a global budget. We have essentially committed New York State to that at this point. It's just a matter of whether or not it's going to be a budget that is developed by New York State or whether it's going to be the specific ahead model.
Oh, okay. No, that's good. Okay. Okay. Sure, go ahead.
Under the health related social needs, I was just looking at the slide, when it comes to the services, level 1 service, how would this correspond with like existing, let's say, health home programs?
Mm-hmm.
Who are already providing case management services, a lot of care coordination. So a lot of nonprofits have expressed, some trepidation. Is this going to replace, the services that they're already providing to Medicaid recipients, their clientele, and the Medicaid reimbursement? How is that going to work?
Sure. So I'll give you a general answer, and I will hope that maybe Lori can provide some additional information for you. So as far as how like the case management and other services might interact with, current services, I think that's going to come down to what the social care network develops within their network, what services they have. I also think that we're going to get significantly more information as DOH releases what they're calling a social care network manual. There's not a lot of details yet. I'm sure, anyone who's applied for the social care network contract is probably sitting there going, wow, what am I even applying for? Because there's just not a lot of clarity on this yet. So the hope is that these will be well integrated and not necessarily duplicative, is what DOH is aiming for here. But Lori may be able to shed some more light on that for you. As far as reimbursement, again, we do feel like that's going to come out in the social care network manual. But in the beginning, it is going to be a flat fee, so fee for service, and then eventually transition over to a pay for performance, value-based care kind of situation.
Any other questions? Anybody, nothing in the chat? Nothing in the chat. Nobody's raised their hand, no. Nothing.
Okay.
Well, thank you so much, Colleen.
Yes, absolutely. It was great to talk with you all.
Yes, and great to have you here, so thank you. So we'll move on now to Lori Andrade?
Correct us, Lori. Is it Andrade?
Andrade.
Andrade,
Thank
yay.
you.
Okay, Lori Andrade, Chief Operating Officer for the Health and Welfare Council of Long Island. And their organization is applying for a social care network grant or whatever you want to call it. And I think that Lori, we've gotten this kind of a state overview. Lori's gonna dive deeper into what that social care network would look like, what the Health and Welfare Council is doing to pull that all together right now, and perhaps maybe answer some of the questions at a more local level that Colleen couldn't answer. So, and also we're spotlighting the Health and Welfare
Yes.
Council as a collaborative member. We do that every
Typically more
quarter.
random, but since this dovetails
Yeah.
so nicely with Colleen's presentation, we thought
Yeah,
it would
and
just
it's
be a
so
nice fit.
timely.
Nice fit.
So we thought, we'll highlight all the great work, and kudos to Health and Welfare Council.
Is it okay if I share my screen?
Absolutely, yes.
Thank you.
You should be able to.
Excellent. So just everybody see my screen?
Yep.
Yes,
There
we
you
do.
are.
Okay. There we go. So thank you so much for inviting me to be spotlighted today and to really be able to talk about the social care network and how it the development of the social care network on Long Island. And thank you to Colleen for that overview, because really I've been laser focused, of course, on the social care network, but where it sits with the rest of the waiver programming is really important and is exciting for New York State and certainly for Long Island. So I'm the Chief Operations Officer at the Health and Welfare Council of Long Island. We are the umbrella organization for all health and human service agencies since 1947. And one of the things that we do in partnership with our network of CBOs or nonprofit organization is coordination and collaboration of the sector. And one of the things that have come out we lead as the Health Equity Alliance of Long Island, which was birthed during the first waiver, 1115 waiver, DSRIP, through the CBO planning grant. And we've been leading and convening on HWCLI ever since. And so it's really been over since 2018 that we've been really building out the technology infrastructure so that we're really ready to transition HWCLI into the social care network for Long Island. And we're excited to be able to apply for the RFA that's currently out. As Colleen said, for Long Island, the Social Care Network RFA that is currently here for CBO capacity building is a little over 42 million for Nassau and Suffolk counties. And those dollars are meant to engage CBOs in capacity building, direct investments into CBOs, as well as training and technical assistance. And the state has this particular definition around CBOs, which again, as Colleen mentioned, there's going to be this manual that comes out, which provides us with a lot more detail. But currently the CBO definition are nonprofit organizations that do not provide clinical services. As well, to engage a larger network of agencies, the CBOs, as well as other providers of care for Long Island, to be able to create a network for Medicaid members, as well as technology and data analytics and contracting and fiscal management. As Colleen mentioned, RFAs are due next week. We are crossing our T's and dotting our I's and ready to submit for next week. Awards for June 1st with that manual, which will have a lot more details, as well as the ability for those of us that are applying to be on social care networks to be able to engage with the state. At this time, as an applicant, we're not engaging with the state, so we're very excited to ask some details and some questions. Emily Engel, who runs the Health Related Social Needs Bureau for New York State, has often come to speak with HWCLI, which meets monthly. And so we're really excited for her to come back and answer some of our questions that we all have. State funding for social care networks are beginning on August 1st. And we'll need to really infuse out those CBO capacity building dollars over that initial time frame to be able to stand up operation in January. Colleen said already that this is really what we're looking to build, is a social care ecosystem where one really doesn't exist on Long Island right now. The blue is the social care network, and the CBOs, as discussed, you know, those nonprofit organizations, non-clinical, grassroots, in-community social advocates. The purple is managed care organizations, health systems, IPAs, health homes, FQHCs, those other nonprofit organizations that provide clinical case management. And then our local government as well, our DSS, our departments of health, our jails and prisons. And together, Medicaid members in the center, and of course, this is focused on Medicaid. This is a Medicaid waiver. We know that we of course, we're looking to serve other folks in the future as well. But right now, we're focused on Medicaid members and really being able to collaborate cohesively to provide social care to these individuals in a very comprehensive, cohesive, integrated manner. Colleen kind of went through this also. The Long Island Medicaid members, of which is about 730,000 Medicaid members on Long Island, all 735,000 will need to be screened using a specific screening tool chosen by New York State. It's the CMS screening tool with a little tweak, as I understand it, for New York State, referral and navigation. On Long Island, we have chosen Unite Us to be our referral platform. And we're very lucky that we have 3 health systems, Northwell, Catholic, and Stony Brook, who are also on. Our 2 federally qualified health centers, our health homes, as well as the social care network, will all be using Unite Us. So that's great, right? So we're all comprehensively using the same network to screen folks, refer, and navigate them to traditional social services like SNAP and WIC and those sort of things. And the state's looking to track the referrals to those traditional social care services, because we know that there's going to be an influx. Now that if we're going to be aiming to screen all Medicaid members, there will be an influx in those services, and we'll need to be able to track what that uptick in need is, or demand is, for those services. And then, as Colleen said, there's a smaller subset of the population, those special populations that she noted, that are eligible for enhanced services. Of that, there's about 240,000 Medicaid members on Long Island that will be eligible for these enhanced services. The enhanced health related nutrition services, the health related housing supports, case management, and transportation. I think what the question about the health homes, and you know, I meet very regularly with our health homes to speak about this so that we have a smooth transition of care related to case management. The last thing an individual needs, if they have a MCO case manager and a health home case manager, multiple case managers, is another case manager, right? But this, as I understand it, and again, we'll have more detail from the state related to what those enhanced case management services are. But as I understand is, these are new services that are not currently being provided, those nutrition and housing services. And the idea is to provide care management around these services and around other traditional social care services. This is not clinical case management at all. It is really meant to be health-related social needs care management to ensure that people are moving through this new system and if they need additional assistance and support. As Colleen also mentioned, there's going to be a predetermined template where there'll be reimbursement for the screening, the navigation, as well as these services. And that will all occur in Unite Us. So the referral, the navigation, the documentation of those services, as well as payment for those services, will all occur in Unite Us. I'm going to pause for a minute. Is there any questions right now on those pieces? I don't want to get to the end. I figured I'd rather take questions as we come. Anything related to that? Okay, so a lot of this will be us coming together as a network, as a social care network, and really determining the way in which these services are provided, and then the data to ensure to see which services work and are most effective and have the most impact. So our healthcare, our network, we've, as part of the RFA application, we are required to survey our network to see if they're, to ask them if they're, would they like to be, submit a letter of intent to be a part of the network. It's not a contract, it's a letter of intent saying, yes, we would like to be a part of this network, as well as a survey so that we can identify if we have sufficient network adequacy to screen, refer, and connect people to those enhanced services. So we have over 100 at this point, CBO and provider letters of intent. We have really good comprehensive service delivery from Elma to Montauk, as well as every language, race, and ethnicity. So we feel that we are really going to be able to comprehensively serve folks and be able to screen them, as well as we have about 17, it says 14, but it's about 17 or 19, I think, letters of support. So letters of intent are more into CBOs and nonprofits. Our letters of support are coming from additional folks like our health systems and our some managed care organizations and our health homes. So we have a really great network right now that we're applying for to be the social care network. And then kind of looking deeper into that survey, like I said, we had to do a survey that kind of identified, and then these are self-reported information back to us from our network, but looks like we'll be able to touch sufficient number of Medicaid lives. We have folks that are interested, are either currently using a screening tool and screening folks, or are interested in becoming or in being trained to provide that screening tool. I think that's probably the place where it's going to be the most challenging as we stand up the network. I think people use screening tools, not necessarily the CMS screening tool. I think they use their own, is what we understand more. And I think some people use the Prepare tool. There's a bunch of different tools that are out there. And I think moving us to a place where we're all using a common screening tool, and not just using the common screening tool, but using it in the same way. Because this is our first opportunity to really collect social care data for our region. And we want to make sure that we're, collecting the highest quality and most comprehensive and as well as uniform data across the region. So I think that's going to be a place where there's going to be a lot of training and opportunities for us to get on the same page about. And so these are the other places. We have actually now probably about 50 organizations that are have onboarded onto Unite Us. These are the special populations that Colleen had mentioned before. And so we have good comprehensive network adequacy related to CBOs and nonprofit organizations that currently serve these populations, as well as those services, those enhanced services that Colleen mentioned. These are the nutrition ones. We are able to meet the needs of our communities, as well as we'll also be able to provide training to be able to see if there's additional organizations that want to provide these services. Housing, again, we have good network adequacy, as well as case management and transportation. The Health and Welfare Council of Long Island, as the lead of HWCLI, has some significant responsibilities, over this time period. Governance and operations, CBO network development and capacity building, probably the most primary one that we're responsible for, to ensure that people have the services and the training and the capacity to engage in this work. The IT platform and data reporting, as I mentioned, we're using Unite Us as our referral platform. Contracting and fiscal management is our responsibilities in order to ensure that we're able to execute as a social care network collectively. And I often say this is really going to be about all of us coming together and figuring out how to do this. As Colleen mentioned before, some of this is the social care network, figuring out the best way in which to comprehensively provide these services. And it's going to be a collective buy-in, right? We're all going to have to kind of roll up our sleeves and do this together. That means providers, CBOs, nonprofits, managed care organizations, FQHCs, everybody at the table together, working to roll up our sleeves and figure this out. The state requires a governance committee. HWCLI has had a steering committee since 2018 that's convened monthly. There's some additional requirements of the governance body that will be expanding that steering committee to be able to meet the needs of the requirements of New York State. And then those additional committees underneath are ones that HWCLI has identified that we want to put together to ensure that there's the the way in which we can bring folks to the table around the different areas that are required of the social care network to have it be really a collective effort. So these are some of the ones that were tentatively put in place and we'll be building over time. And we really encourage people to come to the table for. So next steps, just one last slide. So we're applying next week. If you have not yet provided a letter of intent or a survey tool and you would like to still do that, we can certainly get the letter of intent in. I think a lot of our survey results have moved forward already. We encourage you to onboard onto Unite Us. It is free for everybody across Long Island. We'll be contracting with Unite Us. Everyone will be able to be a part of Unite Us for free. So we encourage you to come on board and get your feet wet in learning how to use it. We'll provide you with comprehensive service and support to work through your workflows, because we know any change, any new technology requires a change in workflow, but we'll be there with you to do that work. And then we have upcoming meetings. As I mentioned, we meet monthly for HWCLI. That will be April 17th. We have Unite Us information sessions. If you've never heard of Unite Us, you want to find out about it. Our next one is April 2nd. We also have Unite Long Island meetings where we kind of go through who are the new folks coming onto the network. We just had one yesterday. So we'll have another one in April. But really, I encourage you to become a part of this. If you have questions, please reach out to me. And this is an exciting moment to build out the social care infrastructure comprehensively to meet the needs of Long Islanders. And I really hope that you'll be part of it. Thank you.
That was really good, Lori. What strikes me about what's happening here, it's very well organized. There's consideration for consistency and unity, right, by using Unite Us and getting everybody to use that. The fact that you've identified for all those different types of populations adequate capacity among CBOs and providers to service them, I think I think it looks a lot better, dare I say, than District did. So and really did a great job. Does anybody have any other questions?
I have a question. How does this Medicaid eligibility tie into MCTP eligibility? Because MCTP is a little bit, different situations with MCTP than versus regular Medicaid. So will this apply to MCTP individuals as well?
So everybody will be able to, every Medicaid member on Long Island will need to be screened and referred to traditional social services. So yes, everybody. And then in terms of those enhanced services, it's Medicaid managed care within those target populations or those special populations.
Okay, yeah, because I would think it would be more on the enhanced side because they're all cancer patients. So okay, all right, thank you.
Any other questions? Okay, I have a question.
So Lori, as far as the letters of intent, Nassau County Department of Health and Nassau University Medical Center, they haven't signed on? Are they part of it?
So I've been in touch with the Nassau County Department of Health, and I know they're considering it right now. Suffolk County has sent their letter, and we're hoping that Nassau County will as well. I haven't been in touch with New Health recently, but certainly there was we started to have some conversations, and we would love for them to be a part of this.
Okay.
There have been some administrative changes that might make it a little hard to know where to go. So
yeah, we've been waiting for that, for perhaps a little bit of the dust to settle there.
Yeah.
Okay.
Yeah.
Thank you.
Any other questions?
Okay. So I had a question. So for New Health, let's say they don't sign on. How does that, they're a safety net hospital. So how would that affect them as far as, I don't even know. I'm just more concerned about the end user.
Yeah.
No, I hear you, certainly. So we began to have conversations about onboarding them onto Unite Us before some recent changes over there. And so I've just been, like I said, so we had scheduled a demo for their folks there, and really we're encouraging them to, knowing that they reach a very important population in Nassau County. So I think we will circle back, as I said, as the dust settles there and that some of the administrative changes are finalized, and then be able to re-engage. But absolutely, they are an important population in which to ensure that we're connecting them to services. I agree.
Okay. Mhm. Anything else? Nobody on the chat? Nothing in the chat right now.
Just really quickly, so for the assessments, who are you expecting to do most of the intake assessments? Is that clinical? Because I know that it's focused more on non-clinical services. So to get them to say, because I think you said a couple of times referral. So you're expecting the clinical side to do the referral, and then how much knowledge are they going to have about what happens so that they would, if they're doing the assessments, the patients would have questions, et cetera, so that the communication would be seamless.
So, all folks will be able, who are on Unite Us, be they health systems, any type of provider, will be able to get reimbursed for those screenings and those referrals. And we will encourage all folks that have connectivity to Medicaid members to do those screenings and to assist with those. And so we're hoping that it will be our FQHCs, our health systems, our CBOs, all will be who connect with Medicaid members would be screening. Unite Us allows for those referrals to be tracked and closed. So the person, so let's say an individual, a provider screens somebody and makes that referral, Health and Welfare Council will be responsible for ensuring that referral is received and taken care of, and that the final, what happens with those folks are documented in Unite Us, and that referral is closed. The person sending the referral will be able to see that journey, that referral journey, so to speak, and be able to ensure that their client receives, or their patient Medicaid member receives, the services that they need. So all of that's the nice part about Unite Us, is that it's kind of you're able to see that. Of course, you can only see that for the patients or the clients, Medicaid members that you're working with. So, while Health and Welfare Council will be able to see the full all journeys, Medicaid referral journeys, that what you would only be able to see the one that you're working with.
Okay, that's excellent. That closed loop is important, because that was a people that was missing. A lot of referrals made, but you don't know what happens, so
Yeah.
that's key.
So just so I understand. So like we use Prepare as our intake for assessments. We use Prepare because no PBMC uses Prepare. So if you use a different assessment tool, would that, so the Unite Us is the assessment tool.
So Unite Us is the referral platform. The CMS tool is the tool. And the state has said there are some tools like Prepare that aligns really well with the CMS tool, right? There's questions that are very close. And so we will work with Unite Us and with HealthX to ensure that there's that connectivity, and we're able to still use those screening tools that are very, very similar by kind of back end connecting those, so that they'll be able to be counted as well in terms of the screens that we need to perform on all of the Medicaid members, as well as ensuring that those providers will be reimbursed for those too. So that'll be a piece of what we need to work through as we understand better from this manual, because I understand that there'll be additional detail about that as well in this manual, so that all of us, be it Unite Us, the Social Care Network, different major providers that use different tools, will be able to connect it with HealthX and be able to do that. I mean, there is a challenge. There are two major health systems on Long Island that are not going to be on Unite Us. That's Mount Sinai and NYU Langone. So just to address this proactively is, we are working with them as well to ensure that we can receive those referrals. Those screenings and referrals will occur in a different platform that they've chosen. And those will hopefully receive those referrals in real time and be able to meet the needs of those Medicaid members and connect them to services as quickly as possible. It's not ideal. Ideal would be everybody on Long Island. All providers are using the same, is using Unite Us like the majority are, but that is not the case.
And do you think it'll cut down on the overlapping of intake? Because when we do assessment, then they go to the provider, they get an assessment. Then when they go to their referrals, they get an assessment. So I almost feel like we're overlapping a lot. So if we can just
Right.
log in and see that they already have these services, then maybe we don't need to do
Mm-hmm.
so
Right.
much. We all have access to it.
Exactly. So you'll have that access. You'll be able to go into Unite Us, look that person, that Medicaid member up, say, oh, wow, they've already had their screening done. And oh, look, they have referrals that are already done. So it's one screening a year unless there's been a change in their social care situation. And then there can be a second screening that's done, because it does happen that way, right? We know that sometimes it's also how open somebody feels in that moment to share their very personal information related to their most basic human needs. I mean, people are opening up and sharing that information, right? And there's different comfort levels depending on a variety of things, right? So we want to ensure that we are capturing that information and sharing it so that people aren't screened over and over and over again. The idea is to have one screening that's done, hopefully capturing all of the information. If nothing changes, that referral goes on the referral journey. If for some reason you look somebody up and they've already had a screening, but there is a change in their situation, then you can rescreen them. You would still get paid for that second screening because it's a new situation, and then refer on to other services as well that they may need.
Well, Lori, quick question. So it doesn't sound like that they're aiming toward a universal screening tool. Like it sounds, they are.
Well, so yes, there's but there's some screening tools that we know are being used out there comprehensively. And so I think the idea, and again, we'll know a lot more June 1st when this manual comes out, but how do we kind of connect those questions that are nearly the same? Because it would be silly to not use those questions. If they're nearly the same and they can be connected on the back end to be able to do that. But the idea is that then the questions are connected to the CMS screening tool that the state has chosen.
Okay.
Mm-hmm. But in Unite Us will be the CMS screening tool. That will be the only screening tool that's in Unite Us for Long Island.
Right. Thank you.
About the data for all of this that they're doing, so will the providers or the systems, I guess would say, and the CBOs get access to that data then if they want to assess that they're happy with how things are going with that patient population, and how much access to that data so that they can do their own analysis and assessment for that subset of the patients that they're seeing that are Medicaid?
Sure, there will be access for each provider to look at their screenings and referrals and the connectivity to services. And there are dashboards that providers will be able to access to look at that, and we'll provide additional trainings on that as well, so that you can access that information. The Social Care Network will be looking collectively across the region, as well as providers, to be able to see that information. But yes, there is, and then I know that there's also some health systems who have their own individual contracts with Unite Us and probably have some additional dashboards and data capacity.
I think we're gonna finally let you go. But yeah, thank you so much, Lori.
Thank you very much, and please, follow up with me if you would like to. You haven't been a part of our Social Care Network and you have interest to be. Thank you.
And good luck on the application, which is due in just a few days.
Yes, it is. Thank you.
So we'll let you, if you want to leave, you don't have to, but if you got to go work on that application, we certainly understand. I know what it's like to be under the gun with those applications. Thank you so much for your time and your expertise in answering all these questions.
Absolutely.
Okay, alrighty. We're headed to.
So our next LIHC update is about our core cluster work groups, which, just to give you some background, we reconvened those groups late last year. And we did choose, based on consensus via a survey, these 3 topics: mental health, chronic disease, and cultural competency, health literacy. Before I go ahead and give updates for any of these, is there anyone here with us who would like to give an update on the mental health cluster? Any participants, either virtually or in person?
I can.
Would you like to?
Yeah, sure.
Thank you so much.
I'm happy to. Okay, so I'll try to put it in just 2 pieces, our purpose and our scope at this point, and then chime in if I missed anything.
Thank you.
So we decided the purpose would be to increase interest in entering the mental health workforce, given the shortages, and secondarily to increase the awareness of the breadth of opportunities in the field. And thirdly, to help people align their interests with a specific profession. So that tended to be our purpose. And then the scope of that is a comprehensive digital and printed documents that can be distributed to those entering, continuing, or re-entering education to support interest and decision-making. Those documents will define the type of mental health professions, the length of study, including intern residency and licensing, the key differences between the different professions, workforce opportunities and pay ranges, and then links to our own provider network employment pages at the Long Island Health Collaborative to include everyone here.
That was
yeah.
like perfect.
I prepared a summary as requested.
Thank you so much. Thank you.
Yeah.
And we'll also have regional resources in there about which universities offer which programming, I think we discussed. So, yep, we're really just in the planning phase right now. And we will be reconvening in April. As you see there, all of the clusters will be. So we'll have more for you at our next meeting.
Right. So, and I guess are we targeting high school and college age? Is that? You know, I mean, you want to catch people who are trying to make a decision about their career, right? So,
yeah.
But it's in the planning stages. So just one quick thing about the core clusters. They're really work groups, but we call them core clusters. And the idea is, and everybody agrees with me, right? You want to go to a meeting, but you want to have something concrete and to show for your efforts at the end of a year or whatever course of time it is. And that's why these 3 core clusters have specific projects that they're working on. And anyone is welcome to join in with these clusters. We don't meet that often, but
bi-monthly, every other month.
yeah,
so
every
it's
other
not-
month. And it, you know, was a little slow going at first, because everybody comes from different organizations and they have their own agenda and concerns and needs. But we felt, well, workforce really is an area, we know this, we see this, right? Even in the waiver, right? Psychiatrists and others in mental health providers, there just aren't enough. And so we said, that's probably feels, you know, can help, can support even what the waiver's doing. So that's why we went that way.
Yeah, so thank you so much, Nadine. Is there anyone on the call who would like to speak to the chronic disease update? If not, I can definitely update the group. Okay, so lately for the chronic disease cluster, we are working on developing a toolkit for young adults who are transitioning into using their own healthcare, giving them resources about how to best navigate that, how to best take advantage of the healthcare they have, and how to really take that into their own hands as they get a little bit older there.
So this might be like a young adult who is college age, you know, kind of, I guess, college age, transitioning. I use my daughter as an example. I hope she's not on the call, but she has type 1 diabetes, and so she is finished with college, and she's still on my insurance because she's under 26, and I'm trying to help save her money, and I have good insurance. Of course, as the mom, right, I was, you know, making sure, take care of the insulin appointment, and she's slowly now, she said, I really want to do this on my own, and she should be doing it on her own, and she is. And so she is, you know, had to deal with the Edge Park, which is the medical device and where she gets the supplies. And she had to get on the phone. It was a little frustrating. And I said, yeah, that's kind of what happens. I said, and I told her you've got to take notes and make sure you know who you speak to. And so she's learning how to navigate the system that I had navigated for her. And there are quite a number of individuals her age that have a chronic illness, a lot of mental health issues, right? There's a lot of in that age group that have mental health issues, and giving them the information and the power and the know-how to navigate and take care of themselves is definitely an important life skill. And we moms have to let them go, right? I have to do this. And so she's doing well. Didn't even know she went to her endocrinologist yesterday. She just came home with the receipt for what she paid for the copay. And I'm like, that's wonderful. So that's kind of where it came from. And I think, was it Stony Brook? Was Analia, didn't you find some research that showed that group really was not being addressed? Was it Stony Brook that did that, or?
Yes, so this is Analia. It wasn't Stony Brook research, but yes, I was sending materials back and forth with Brooke, to be added to the eventual project for this group, that did, look at those, look at that age group.
Yeah.
And see that, those skills waning. We had also, you know what, you might be.
It was the HPV study of college students.
The HPV study, right.
Yes, okay, sorry, I was misremembering because we met so long ago. A researcher here, Dr. Kathleen Scarborough, who is in our family, Department of Family Population and Preventive Medicine, has been conducting research on college students and their knowledge, like attitudes and beliefs about the HPV vaccine, which prevents 6 types of cancer. So we work on that, and we've been working with her on this research and getting it out there, disseminating it. And one of the main findings is that the students actually didn't even know their status. Many students had no idea whether they were vaccinated or not, because typically this is a vaccine that occurs in childhood, so it's in their, parents' records. They don't remember it. Nor did they know how to access those records. So we've been trying to help incorporate some of those, basic literacy and advocacy skills within our education here in the COE office.
Odessa, did the county health department, weren't you doing something in that area too, or maybe I'm getting you confused?
Yeah, Tiara Crosby created a website from the Cancer Prevention and Health Promotion Coalition.
Okay.
On advocacy, like how to be your own self-advocate. It's a great website. I strongly recommend it.
Okay.
Sorry, Odessa.
No,
That's something you would incorporate and promote to this small group, this very finite audience that we're trying to target. What was the website? Can you?
Analia just popped it in the
She
chat
put it in
there
the
if
chat.
anyone is interested.
And you'll get
in
it
looking.
because you'll get the slides.
And so, yes, this will be
Well,
like one of many resources
Yeah.
that we will be including in this guide for that audience.
And then the last, anybody's last cluster?
Would anybody like to speak to the CCHL cluster? Who's on the call? If not, we can update, but love to hear from you guys doing the work too.
That's you.
All right. So you might remember from some years ago, the Long Island Health Collaborative had a train the trainer model with our cultural competency health literacy training. We are working on kind of resurrecting that and creating a static module, that we can house on the collaborative website that any CBO could take, within an hour and get a certificate that just says, they underwent this training. And so we're working on developing that now.
Yeah, and I think we had members on that cluster. There was somebody who's looking into accreditation and to see if there was something like this already out there, because we're not going to do something if it's already out there.
And we were thinking of differentiating it by incorporating some Long Island specific history, regarding culture and historic
events, right?
Yeah, that could, give more insight into the current state of Long Island today,
Right.
and regionalizing it that way.
Particularly with health inequities and health disparities that
Yes.
stem from our region that continues to be one of the most segregated regions
To this day.
in the country. And there's a whole history right behind that generations of today don't really maybe understand. So we thought that would be important as a context to put in there. And again, anybody's welcome to.
If any of this sounds interesting, you want to join, please
Yeah.
just email me,
Because
we'll add you to the list.
Our deadline is to have all of this done by the end of this year. and it's March, so it's still doable.
And meeting every other month,
And
yeah.
yeah, but that's what we would want to do. And then next year, new projects. And then, you know, I foresee perhaps at some point us collectively working on some kind of a research project and trying to get it published somewhere. I'm not sure what that would be, but it's just something, you know, a thought that I have. Because the idea of the collaborative, right? Oh, what do you?
I have an hour, don't worry.
Okay. The idea of the collaborative, right, was the collective impact model. We understand, right, backbone organization gives support, convening, doing some data analysis, but everyone together, more hands together, more people working together, there's a greater impact at the end, but you also each get to take credit for all that's done too, and that's important to remember. So,
and my colleague Ramona, she'll be reaching out to you all to coordinate the next April meeting, so be on the lookout for that.
Yeah, and April's here before you know it.
It's in a few days. So moving on, we have an update by Francesca Dam, our program director here of health insurance programs. You might remember we kind of discussed at the last few meetings our Keep Long Island Covered initiative to inform Long Island Medicaid recipients about the end of ongoing enrollment that ended with the public health crisis. So I will turn it over to Francesca here to give a final update about the grant, which has concluded at this point.
Good morning, everyone, and thank you so much for having me. I'm really excited to be here. I'm actually a new director. I've been here for 3 months, actually. But I'm really excited to just let you all know how successful this was. First and foremost, I just wanted to thank everyone here for taking flyers. I know that flyers were put out at some of the meetings, and that really helped with our outreach efforts. Our efforts help reach over 1.5 million people monthly, which is just insane to think about. That's a huge outreach. Not only the flyers, but with the Health Collaborative, they helped with social media posts, newsletters, public transit campaign, posters, radio advertisements, print ads, radio, blog posts, things like that. My team actually also assisted with some of our postcard outreaches. So this was just to let them know, hey, we might have helped you in the past. We know things kind of changed. If you need help renewing your health insurance, give us a call. We'll be more than happy to assist you. So with that, we were actually able to successfully help over 1,600 Long Islanders in retaining their health insurance. It was a really
very short period of time.
Yes, yeah. Because when you think about it pre-COVID, you know, this was normal. The community was used to doing their recertifications and their renewals every year. But now you had this population of people, COVID happened, they don't know what to do. So that's why I'm glad that we were able to be there and assist them through that process and walk them through and help them retain the coverage, especially when they needed it. So I'm really proud in the short amount of time. I'm really proud that I was able to see the impact that we made with this. And you know, the grant was just super successful. I'm really happy. With Nassau Suffolk Hospital Council, we also, you know, we go beyond just that one grant. We have our FE-ABD program as well. So I do have facilitated enrollers that go out in the community within Nassau and Suffolk. Usually libraries or senior centers, and we help those get New York State sponsored health insurance. It's primarily for the aged, blind, and disabled community, so that's what ABD is for. But you know, the Medicaid applications are extremely difficult to navigate, so that's why we're there to help them. We kind of guide them through the application process. We send out our calendars, you know, monthly. It's posted on our website, and I know that the collaborative also sends it out for us to get the word out there. But it's really important for us to be able to be that advocate for people in the community that don't really know how to navigate those programs. Speaking of advocates, we're also community health advocates. So we help navigate not only Medicaid applications or New York State of Health sponsored insurance, We also, you know, in those conversations, they may need help with applying for financial assistance for their hospital bill that Medicaid might not cover and backdate for them. Or maybe they need help with appealing something with their health insurance. So we go beyond just doing that. We do whatever we can to advocate for our community, our patients, our clients. And we really do meaningful work. So I'm really, really proud of it.
Yeah, and
You do.
And any community-based organization that has kind of a public-facing opportunity, Francesca,
Yep.
you know, contact her. She's happy to send enrollers
Yep.
on site. And they really do a phenomenal amount of work with a very small staff. So, and Francesca's only here a few months and she's been fabulous. So thank you. Anybody have any questions for Francesca?
Besides doing the enrollment, do you do presentations to educate on how, you know, what you do? And more specifically, helping seniors navigate the Medicaid application?
Yeah, so I'm definitely looking into doing some seminars as well, just for education purposes. Because like I said, a lot of our community members, they come to our enrollment sites and they're expecting almost a seminar like, hey, I have a question about pooled trusts, like what do I do? So I am definitely looking to do that in the future. I just haven't done it yet.
Okay.
Maybe you could be the.
Yeah,
test
I got your business card. My business card's actually on the table, so
Okay,
yeah, I got your contact information.
And it's all free, right?
Yes.
Because there's no
Everything's free.
cost to anyone,
Mhm.
so. Okay, thank you so much,
Thanks so much.
Francesca.
Thank you.
Can Francesca put her information in the chat? And then also, is there a calendar of where you will be when, or where the enrollers are throughout the community so that I can do that with me when I'm out in the field?
So I failed to include Francesca's contact information on her slide. I'm going to add that before the slides are distributed. But there is also a calendar on the coverage for healthcare website, which I'll include that on the
Yeah,
slide
that's,
as well.
it's coverage, the number 4, healthcare.org.
I'll put that in the chat.
Yeah, and that, it's all listed there. You have it out all the way for the rest of the year, right?
Yeah, I have it completed for the rest of the year.
Yes.
I am trying to build more relationships in the community, and I'm trying to kind of branch out more into Nassau County. Right now, we're very, very Suffolk heavy, but we kind of move where the community needs us. So if we're having a lot of clients calling us from a certain area, I try to find a centralized location that makes the most sense for people to travel. Some of our locations we're there twice a month. It just depends on the volume. I mean, people are waiting for us when we get there. So there's usually a line waiting for us. There's no appointments. So it's first come, first serve. But yeah, all the information's on the website.
And those events are always at the top of our collaborative communications email blast. If you ever are curious and you get that email, it's right at the top if you want to see the dates. Thank you so much.
Thank you.
What else? What's next?
Alrighty, what's next
What's
here?
next? Because we're.
So some just quick prevention and
Oh,
treatment
yes.
updates.
And my Suffolk County colleagues, somebody else, Jack Sherman, I think, right, would be interested to hear. I mean, you probably know about this anyway. But, so the next 6-year cycle, 25 to 2030, God, 2030, is in the works right now. So, what the state is doing, that there's an ad hoc committee for the prevention agenda, which is part of the Public Health and Health Planning Council. That ad hoc committee is in like a consultation body for the prevention agenda, providing advice, and it's a huge statewide group. But most states, we've heard from the DOH, has given a number of presentations. It says a lot of states are moving away from that disease-based priorities and shifting more toward a heavy social determinant of health model. And right now they're proposing 2 frameworks. I'm not quite sure I understand the complete difference between the 2, but the way I'm getting it right now is the current format with the 5 priorities and adding some social determinant of health topics, and or following the Healthy People 2030, which has a social determinant of domains in there, and leaning much more heavily on social determinant of health factors. They are trying to streamline and make the process a little bit easier to get through. A survey, they sent a survey out, the prevention agenda, the state, you know, people working on the prevention agenda, state to stakeholders, right? To want to find out what were the priority topics. Those findings are going to be presented to the Public Health and Health Planning Council in a few weeks, right? Because they're the ones eventually will vote on the next prevention agenda priorities and the framework for it. I understand guidance will be finalized and posted in the summer of 2024. And in December of this year, FIPIC will have the new action plan in place. And then the full first 3 year, 2025, 26, 27 community health needs assessment, community service plan for hospitals, community health assessment for counties, and community health improvement plans for counties. It's just they're kind of the same thing. They have different names. That'll be due a year from now, a year from December. Just as a quick update, you will recall that you'll have to do your 1-year update for the current 3-year cycle we're in by the end of this year. So we'll have more about that as we move along. We did throw in there a timeline. Can we click to the time?
This is that letter from DOH.
Yeah.
That you probably have all seen before.
I'm sure you've all seen it, but I actually have it up on my bulletin board because I always have to refer to it because it gets very confusing. This like 1 year that overlaps every 3 years or so. It gets a little confusing, but this gives you the dates, right? December 31st, 2024 is an update. For some reason last year, December 31st of 2023, the state said we didn't have to do an update. I don't know why, they just waived it. Maybe they'll waive it again this coming December, I don't know. But then we go into the planning for the next 3-year cycle, 25, 26, 27, right? That 3-year plan that will be due the end of 2025. And that's when we put together here not an ad hoc.
Our work group.
A work group. Well,
We don't like the term work group, but.
It's not we put together a work group. We call it a prep, you know, a CHNA prep work group that is comprised of hospital members and county health department members, some CBO members too, right? Because they're important in this, even though they don't have a mandate that they have to do these community health needs assessments and service plans. They do have important input regarding what the needs are in terms of the communities they serve and what eventually will be the priorities that rise to the top, which by the way, they're always and have been since the last 10 years or so. Chronic disease and mental health substance misuse. They just keep rising to, and I imagine that it's funny that 2 of the core clusters are that chronic disease and mental health. So I imagine that's probably what's going to happen again, but maybe not. So we will be putting that together. Last year, or the last time we started in September of 2021 and carried through to May of 2022, right? Looking at data, we did key informant interviews, we surveyed community-based organization leaders, we looked at our community health assessment data that we collect on an ongoing basis, which Melissa's going to talk about our 2023 results in a little bit. And we pull all that together and we have conversations with those who are on this prep group so that everyone, because ideally what the state wants is for regions to select hospitals and the counties that are working together to select and work on the same priorities. That's the idea. And we've been doing that, you know, we choose priorities, but not everybody has to do the same interventions, right? There's different interventions and programs. So we'll talk more about that in June. I don't want to talk, it's too early to start talking about that now, but that's where we're headed. So we're gearing up for that, just so you know.
So it'll be interesting to see what this final framework that they've decided upon looks like. Is it going to be maybe only three priorities and 3 social determinant of health specific topics? I don't know. We'll just see what it is. And as soon as I have it, I'll share it with everyone.
Alrighty. So that brings us to our 2023 Community Health Assessment Survey Analysis results, which Melissa Bauer from DataGen has been kind enough to join us and speak a little bit about. She performs the analysis for us every year. Just going to spotlight her.
And
here.
we have summary documents over there. There's 6 questions. There's some demographic info that's collected, but then there are 6 questions. And what this really is doing is asking about an individual's perceptions of their own health needs and barriers and what they see are the community's health needs and barriers. And it's been the same questions that we've been asking when just a few of us met in a small little room 10 years ago, 12 years ago, when we thought we would just do this once and, well, there's a whole history behind it. But so anyway, here we are this many years later, and we're still asking the same questions that we've amassed about 17,000 surveys at this point, and you can go in and it's in Power Pivot format. You can do your own reports. We can help you do some of those customized reports if you need to. And you can see trends. You can see where we've gotten better, worse.
Which I think Melissa is going to discuss a little bit too.
So I don't want to steal. Melissa's the data analyst. I'm not a data analyst.
No, you're fine. You do great work though. Thanks for having me. So these are the 2 questions that have been pulled out and they're ranking for Nassau and Suffolk County. So we'll just talk about this a little bit first. One thing that I noticed was that between last year and this year, those top 5 ranks didn't really change that much for either county. But what did change was for Nassau County, cancer kind of topped mental health and depression, suicide, which has been at the top for several years for that. What are the biggest ongoing concerns in the community where you live? But an interesting thing happened this year with the respondents of the data set. When we look at prior years, and I'll just kind of look at the data between this year and last year, there's a much higher percentage of respondents that are women. It's roughly around 70%, where we usually have a 50-50 split between women and men. And also this year, the age group that had the highest percentage of respondents was 65 plus and retired. Previously, it's been in that 45 to 54 range group, working for wages. And what I noticed was that things stayed the same, even though those demographics changed. So these top 5 ranks for all of the questions, not just these top 2, stayed roughly the same. And then things like race, income, and insurance status, those are roughly the same as they were last year. And I did find it was interesting that even though Nassau County changed, like I said, for the health concerns in the community, they went from their top rank being mental health and depression to cancer. Suffolk County stayed the same with mental health and depression as the top ranked concern. And then, as I said, those top 5 for both were roughly the same. And I did find that interesting because the demographics, those age and gender had shifted. So it kind of shows that you're looking at, even though separate populations, you're seeing the same types of concerns across the community and for self. One of the questions that Janine and Brooke asked and were concerned about was if 403 surveys, was that representative of a sample? And so we did an analysis based on the population using a 95% confidence interval. And we did discover that we are within the realm of just about 5% confidence that we are capturing the appropriate number of sample size respondents to be able to say, yes, we are getting a representative sample for both Nassau, Suffolk together. And a thing that did change is, and that everyone always asks, is the number on the overall results doesn't add up to Nassau and Suffolk County. And that is because some of the respondents do live in Queens, or they elected not to tell us which county they live in. So that's why if you added that total together up between Nassau and Suffolk, it would not add up to the overall results, because we did have some respondents that elected not to tell us where they were from, or they were from Queens. And because we get such a low number of respondents from Queens, we don't do an analysis for them because their numbers are so low. And let me just pause here to see if anyone has any questions.
Melissa, I'm sorry.
Go ahead.
I wanted to ask, because you said that you were within the 5% confidence rate to ensure that it is representative of the population. Does that include the race of members on, Suffolk County and Long Island? Like, do we know what percentage of race ethnicity is answering these questions?
We do know that, and we did not do the confidence interval analysis based on race. I can tell you that historically, overwhelmingly, and unfortunately, the race that responds the most is white. For example, this year, we had 84% of white people as respondents. And then the next category we received is 5% for African Americans. So it's every year we overwhelmingly see people that are white responding as far as the race category. And I can tell you the counts for overall, we had 291 people between Nassau and Suffolk County that selected white as their response, and only 18 people that were Black or African American. So I do think that there is opportunity to find ways to distribute this survey to a more inclusive population in terms of race, ethnicity, even age range.
Thank you.
Absolutely.
Yeah, I mean, so the distribution and, well, distributing it is not as, well, that's a task too, but the greater task is getting the individuals to take the survey. We all know this, right? It's very hard to get people to take surveys. So prior to the pandemic, we certainly were having more surveys returned because organizations were holding more in-person events, and they were handing out, believe it or not, paper-based surveys, which is fine, and we still accept them. You just return them to us and we enter all the data, so you don't have to worry about that. Of course, it's easier if they just, we'll do the link or take that QR code and fill it out. But so then the pandemic came and we didn't have a lot of events happening. We really struggled through social media and sending flyers to the library, asking them to post it up with the QR code, any method we could think of, right? And we didn't have any money to spend, but we did spend some money though on boosting.
And we have that in our budget again this year.
Yeah, we spent some money to target zip code areas where we would get more of a diverse population to respond. And, but again, I'm sure you're all on Facebook, Instagram, and you see all these ads pop up, take this survey, it's just very hard to get attention. I mean, I kind of used a little bit of a humor, and because we got a pile like this of surveys, right? So I'm afraid to throw them out. They're locked under, well, they're anonymous, so you don't really know who it is, but I'm afraid to throw them out. I'm afraid, I don't know what to do with them. And I said, you know what, let's take a picture of this big pile and try to be creative and say, this isn't just another pile of papers, you know what I'm referring to, right? And I thought, oh, maybe this will catch people's attention. So I don't know how well that went over, but we come up with all these different ways to present it. And we have a toolkit which you can use. It's got.
And we'll talk about that.
And we'll get back to it. But the point is, we do rely upon collaborative members to push it out. It's in our collaborative communications all the time.
And some of our partners do have great success with the
Some of our
paper
partners,
surveys still.
We thank you, right, so, you know.
We're happy to enter them, you
Well,
know,
and-
however you can get
Yeah,
folks
I
to
mean,
answer.
we're happy, we'll manually sit and enter the surveys. If you have a population that still wants to do the paper survey, that's fine. We hold some events at the collaborative, and Brooke and I have been known to basically chase people down to get them to fill out
Sorry about that.
surveys. I teach at a community college. I beg them to take the survey, and that's all I can do. I can't tie anything else to it. All I can say is, please, if you so choose, take the survey. Some do, some don't. So I guess my plea is, if you want to see more numbers and more groups and more representation from diverse groups, it just push it out there. Put it in your community newsletter. If you've got an electronic community newsletter, stick the QR code and the link. And we even have, I think, some like a post or a visual you could stick in there. I mean,
So,
we've made it
yeah.
as easy as possible.
We do have a Google Drive folder, which I understand some people might not be
Yeah.
able to access. So if you cannot, please reach out to me directly and I'll email you these materials directly. But so yes, we do have an English link, a Spanish link. We are going to be boosting the links again this year on social media to those geographic areas. And yes, in the toolkit, we have QR codes, social media graphics, and social media posts where you can plug in your organization name. And we can always co-brand those posts for you. If you're interested in having your logo added, we can do that for you and get that to you in like 48 hours.
Right, and so it's to your benefit, right? The more surveys that are returned, Adesua, right? You understand that, right? So you'll get that representation that you're looking for. If it was an ideal world, I would go and I would rent household lists, and I would or text numbers or something.
Put a lot more funding behind it if
You know,
we could.
if I
yeah.
had it, that's what I would do. You know, I would do random sampling. And I'd hire a firm to keep calling until we got what we felt were enough, you know, a lot more numbers, but we don't have that. So we have to work with what we have, which is, you know, a zero nest egg. So that's what we do. You know, but we do, how did we get that little bit of money? The council is supporting that. The council is supporting that. So,
Yeah.
Question, have you guys partnered with CBOs who incentivize their own testing and just kind of threw it in there? Cause like, for example, for like the stuff that we've done, we partner with like, Northwell has a program where they go and do AIDS testing, HIV testing, and they incentivize people taking that test, but they have to fill out paperwork in order to get the incentive. So you can just throw it in there, you know, like how sometimes we throw in our referrals as well, because they're already sitting doing paperwork anyway. And, you know, just included in the incentive. Like EOC has a similar program where they go and do door-to-door testing, and those people get like gift cards to whatever. So then kind of throw it in there and then have them send it back to you.
that's an avenue we could explore. We might need to follow up with you. a little bit
Sure,
more.
I would too, Neil. It's fine.
Connect to ELC.
EOC, yeah. Yeah, I mean, even the FQHCs, they were handing out paper copies and had them available in the waiting room, but then, you know, as I said, COVID hit and everything just kind of went upside down. So I do want to reconnect with them too and see if I can get them to
Yeah,
get some
and
sort of back to
don't
us.
be afraid of the paper copies anymore either, because I recently came into the possession of a scanning software. So if you all want to mail me your paper copies, you don't have to hand enter them. I can scan them.
Oh.
Nice.
Yeah, you're welcome.
Great news, Melissa.
It was usually, you know, just
Me or Alexis or
Yeah, no, don't do that, guys.
to do it. And there were times when we had hundreds of them would come
I
in.
know.
We got it done.
I do recall like some of our programs, you know, we
Yeah.
gave them to Ellen Higgins, you know,
Yeah, tons of
and
it, yeah.
and it was paper.
Yeah, yeah.
And there
was,
are some copies back there for anyone who's here in person, or I can print some up for you before you go if you'd
If
like
you
a
want to
stack.
take
I would
some,
be
but
more
we,
than happy
and we
to.
can send you the PDF, and it's on our website. Which,
Yes.
by the way, I know we've been talking about redoing that
Forever.
website, but we actually paid ahead of time. We had money in the budget, council's budget, to get that website cleaned up. It's just Brooke and I have not.
It is in motion now, though, some of the
We
basic
know what we have to
updates,
do, and we're just gonna streamline it and make it much easier to find the data, everything, 'cause it's,
particularly the
it's,
data.
you know, the collaborative change. Once we lost that state funding, the Long Island Health Collaborative has really, by virtue of just Brooke and I, kind of held itself together, and some, of course, the support of the council to pay for the hosting site and all of that, but, and it's our time that we dedicate to this. So,
If you have a stack, I'll take them. I'll get some to Odessa and some of the
Yeah.
people, you know,
yeah,
who
I
are
mean,
working.
it's, and I understand too that people are tired, they're survey fatigue.
And they're inundated, yes.
I understand that, but we try to explain to them, particularly when we do the, what program is it, it's Walk Safe with a Doc program.
Yes, and welcome.
I explained to the individuals who are there that if we don't get feedback about the programs and how well they do or will not do, then we have to prove to the funders, if it's the state or a private foundation, that it's worth their while to put money into this. So if you want to see more programs like this that don't cost you any money, this is just unfortunately what we have to do. And sometimes that kind of nudges them over. They say, oh, yeah, okay, then, you know, they say, all right, I'll fill it out then, so.
For a younger demographic, have you thought about doing it like masters or like bachelorette programs and asking like the classes that are doing public health or like health talks, if they could slide it in when they have to do other paperwork, maybe at the beginning of the class or the end of the class? And that way you can get a younger demographic who even has a more focus on this, which might skew it a little bit, but at least you would get people who would know about the program more.
I try to get my students to, I teach community health, and I try to get them to fill it out, and I even do have an assignment that I have them to, you know, do connected to it, and
But just sheer numbers on the island, I mean, like Stony Brook has an
Yeah.
MPH and there's a couple other programs.
yeah, I mean,
so-
I'm just talking about one class because it's me, but
No, it's a great idea.
nobody.
Can I ask also, in the evenings, I'm an ESL instructor, so I have a large influx of Haitian Creole. Any possibility this might
Yes.
be because I was able to get all the Spanish speaking students, I got all my students, we got the whole school. But, we have a large population that we had to interpret, and it's really, I think, skewing the data that way, so.
We can get that to you like within a month. We can have that translated
Okay.
for you.
What,
It could be
Haitian
French.
Creole?
Yeah, the updated survey has not been
And that
translated
hasn't
into
been,
Haitian
but we,
Creole yet.
okay, yeah, we tweaked it a little, so we have, okay.
Yes,
And it
thank
could be
you for
French,
bringing that
because I
back
think
up.
that's more more general.
Some can speak Spanish as well, you know, so that was easy, the
Mhm.
Spanish speaking Creole individuals. But
We
there's
definitely
some
want it to
that
be
just
as
only speak
accessible as possible. Yes, we'll
Okay.
definitely do that translation. Thank you for bringing that back up.
Okay, so.
I even went to the hospital, like the offices, I was like, here, give these out
Thank
to me.
you.
Yeah, we try to do it.
I mean,
No,
I-
I've been getting your envelopes. Thank you so
You're
much
very
for
welcome.
sending those.
Yes. So here it is, right, English,
Yeah.
Spanish,
Yeah.
we
So that's
talked,
the
kind of
link.
talked about all this already.
Mhm. Right, and if you can't access the Google Drive, please email me.
What else?
And then just some ongoing engagement updates. We just always remind you that we have our collaborative communications bi-weekly email that goes to all of our members. If you have any free events, resources, jobs you want to include, please send them my way. Our events calendar is also on our website for you to submit any free events. I see Annalia's message. We'll definitely give you that Haitian Creole version when we have it. And Walk with a Doc, Walk Safe with a Doc is our,
And we're still doing those.
Walk with a
We're
Doc
still
is a
walking
national
around
program.
all kinds of communities.
We recruit a local physician from one of our member hospitals to give some health information to walkers before we go on a walk in a location, sometimes at a library, sometimes at a park. And we do have some upcoming walks that I just wanted to bring to your attention. When you see Walk Safe, it's where we incorporate our pedestrian safety partners at the New York Coalition for Transportation Safety. So we have 2 walks coming up in April there, and then we have some other just traditional Walk with the Docs that are going to be hopefully sponsored by AARP Long Island. And some folks on the call were instrumental in helping us organize these, so thank you so much for that. Specifically Suffolk County DOH on that Sunken Meadow Walk, which we're really excited about.
Yeah,
So,
that's gonna be a good one.
um,
And we have for the walk safe ones, we don't do it for the other ones, do we, the survey? I'm never
we have
gonna
a
get-
different survey
Oh, we
for
have
the
a
traditional
So,
walks.
so we have this like very brief survey that we get everyone to fill out before they go on the walk and then after they go on the walk to get some kind of data on knowledge gain and you know, are you gonna continue to do a walking program? It's rudimentary, but it's some data and we analyze that and make that available for anyone who wants to use it if you're writing a grant or whatever you want to conclude it in your CHNA or whatever it is. It's the best we can do in
The
terms of.
safe part, is that just Long Island Health Collaborative adding the safe, or is that?
Yes.
So it's the national program, they don't have a problem with you adding the
No.
safe? Yeah.
No.
So the one that Adesso connected with you, that's gonna be about sustainability, right?
Correct. So that's the reason why we don't include the pedestrian safety in the,
Because
just
that-
because a lot of the time these are at parks.
Right.
Whereas there's not really a lot of, crosswalks and infrastructure to
Right.
discuss as far as pedestrian
Right.
safety.
But there will be somebody speaking about sustainability, about environmental.
Yeah, so the Sunken Meadow Walk is, kind of special in that way. So we are going to have a walk, but we're also going to have Adesso discussing equitable access to Long Island's parks, as well as Jimena, who oversees, actually, Adesso, could you remind me of Jimena's title and role, please?
Sure, she's with the Long Island Estuary Program.
Yes, thank you so much. And she's going to be discussing, the Long Island Sound, how that fits into the estuary program. So it'll be kind of a special event in that way. We'll have some guest speakers that we're excited
Right, and this is the first time that we're partnering with an institution like the Long Island Estuary.
Yes, that's true.
Which
Yeah, on a
is,
walk like this.
and this was kind of this is the, kind of the beauty of the collaborative is how these organizations and initiatives come together. So we have the Suffolk County Department of Health, we have the Long Island Estuary, and of course, we have the Long Island Health Collaborative, and we have the National Walk with a Dock movement, all kind of coming together. And we've done this in a number of different ways, but this is the first time with the estuary, and I'm that one is gonna be interesting, and isn't on it's on a.
Those are all on Saturdays.
They're on
The ones
Saturdays,
at the parks
yeah.
in the spring and fall.
Now, do they, because there's a fee to get in there, right? On
Yep.
Saturday, and it's starting like April, I think.
Yep, our application is all in. I paid the permit fee. We're all good to go.
Oh, so anybody who drives up can say.
She's
I'm
talking
here
about
for
the
walk.
parking.
Oh, yeah, parking is going to be free.
We
Yes.
got that waived.
Yep.
Okay, so the
And that'll all
people
be on
going
our
have to
promotional
say,
materials.
I'm here for the walk.
Right,
Okay.
because we didn't want that to be a barrier for
Yeah.
anyone, so we got that waived.
And what else do we have here? Oh, just one last update about our future meetings.
We're moving.
We are moving. Still in Hauppauge. A little smaller of a
I think
conference
it's
room.
my fourth move with the organization, I don't even.
My first, so.
I believe it's 800 Vets Highway, closer to 111. I'm not 100% sure about that, but it is smaller quarters, right? Because hybrid schedules, everybody's not here. Downsizing. Small quarters. I do not have a conference room like this. I understand that there is a small conference room in our suite of offices, but in the lower level, I believe there's a common room that you can utilize, but I have to check that out. So
When?
So we're moving
When?
the end of May.
May.
So the next meeting, June, will be at the new location.
We will still have this technology though.
Yeah, we will still be able
So
to
we
do
can
this,
still
but,
have hybrid.
but we were so happy when everyone came together in person And I'm hoping that somehow we can still pull that off. I have to go look logistically at what's available and what we'd be able to do, but the conference room that they have for us is maybe 12 people tight, you know, so.
Bittersweet news, yeah.
Yeah, I was kind of miffed when I heard that because actually the collaborative really is the only group that regularly meets now in person. Like all our committees that we hold for human resource, people in hospitals, human resource, nursing managers, nursing directors, fiscal finance directors, they all meet virtually on Zoom. That's what happened.
Something's lost with that.
Yeah, but I'll see what we can do. I'm gonna check it out and if we have that room available to us on the low level, we'll just go on the low level. It doesn't matter. It's just down the block. It's not that we're moving.
Right.
Yeah.
And that is all we had for today with 5 minutes to spare.
Yeah, so it's a lot, we've packed a lot into the meeting, but you will get all the presenters'
Yes.
slides.
The recording,
the
agenda.
contact information. We will be sending out, I think Linda asked, we will be sending this out, Linda, the
Yes.
summary.
And that's already available on the website, but it'll be linked in the slides as well.
And we are going to write a news release about it. Each year Newsday seems to cover it, so we'll see if we can get them to cover it again.
Or thank you all for being
Yeah, but
being
thank
here,
you all for
virtually
being
and in
here.
person.
It's really, it's great for me, and I think I speak for you, Brooke, and probably the new intern too, and our relatively new employee down there. It's very good for us, right? As conveners and facilitators of something like this to interact personally and meet
It really does.
these individuals who you're all doing fantastic work in so many different areas, like what you guys are doing is amazing. I know what the health education project does, so that's amazing. Work that's going on in Horizons Counseling, the county, so it's just great. And Nadine, she's been a lifesaver down there with all her mental health knowledge and whatnot.
No worries, happy to be here.
Yeah, so we appreciate it, I really do, I really do
Very much so.
appreciate it that you, and I appreciate everyone on the call too, right? Just because you're not here, it doesn't mean I don't appreciate you.
You're here.
You're here, yeah, you're here with me. And so we do appreciate it, and it just helps to reinvigorate me at least. I don't know about you, but it gives me a little bit of a.
It does.
You know, because sometimes I get pretty frustrated, it doesn't seem like we're getting anywhere, and I'm sure you guys kind of feel that a lot of times too. But when you get with like minds, you feel invigorated.
I just want to, I was late, I apologize. I'm Josephine Peterson from NYU.
Oh, hi, Josephine.
It's good to see you. And I just wanted, I've been in and out of this collaborative for probably the last 8 years in different capacities at different locations, just because life has happened. And so when I started coming to these meetings, they were next door, actually, went next door.
Yes, it's 1993, because we had so many people, yes.
And kind of popping in and out over 8 years, I just want to say you have made movement. It's so cool to see where you are now and what this group continues to do. And have seen it in my different capacities and roles sporadically over the years. So I'm always so happy. I'm hoping that I'll be here for a while now, but it's nice to be back and part of the group.
Thank you so
I'm
much.
excited to partner.
This is good. Thank you. And welcome to those who I've just met today, and I'll make sure that you connected.
I'm just gonna bring up one thing, the LGBTQ plus advisory board for Suffolk County is having a day of recognition today at the Dennison building. And it blew up on social media. I just posted the event and it just blew up. I think that's a population that's gonna be willing to fill out your survey. And that maybe wants to be invited, to have a seat as well. So I don't know if there is anybody in the collaborative, but just the way this blew up and the support that they're getting is amazing to me. So, yeah. I'm not gonna be there. Tiara's gonna be there this afternoon with a table full of cancer cards because she's part of the, she leads the Cancer Prevention and Health Promotion Coalition, and some on our call are also on that, and I think you are too. She's gonna be tabling there, so
So that's right up the block.
Yeah. Do you know what time that is?
2:00.
Thank you.
Oh, good. And that's it, right?
Yes, unless anybody has anything else they'd like to.
Well, what about
discuss.
the April 9th? What we're doing with Good Samaritan?
I did forget to bring that up. We are having a pedestrian safety panel at West Islip Fire Department on April 9th, in conjunction with Good Samaritan University Hospital. You're right, how did I forget?
I don't know. And that's also in partnership with New York Coalition of Transportation Safety, but they have their trauma doctor talking, and it's in the evening, and they're actually giving people dinner. It's to coincide with spring and kids riding their bikes and more people walking around. And as you know, or may not know, Long Island is very, very bad for bicyclists and pedestrians being injured and killed on our road. Like, we're way up there in the state. We might be the worst. I think outside of New York
Some time
City,
ago,
I think
yeah.
we're the worst. And there's certain pockets, like the Hempstead area. I think there's a spot in Farmingdale.
That's where our walk safe element comes
Yeah.
in too.
So they wanted to do this, and so, you know, I mean, it's very local, right? Because it's in West Islip and it's that kind of service area. But if you happen to be around and you want to get a free wrap, it's at 6 o'clock there. But we'll be there.
And that's in our collaborative communications newsletter too,
Yeah.
if you're interested in learning more.
Right.
Janine, just, you reminded me when you mentioned that years ago, I think like 5 or 6 years ago, our office did a health disparities conference on that, and trauma. So we partnered with Stony Brook's Trauma Center, and that rose to the top, and a lot of Latinx Hispanic community members were also being impacted because they tend to walk or bike.
Yeah.
So, yeah.
And it's just, it's not getting any better. It's, you know, no matter how much education, and that's really what the New York Coalition of Transportation Safety does. It's pedestrian-based education laws, right? There are laws in place that are there to protect walkers, bikers, and motorists. And it's the speed of the cars, it's the size of the cars, right? Newsday just did a piece on those SUVs and how if you get hit by one of those, it's hitting you midsection and you're hitting your major organs, and you're much less likely to survive. And that there have been so many more of those cars on the road. It's just, and then I hear from we've had some parents of victims of children who've been riding home from school and gotten killed crossing the street with their bikes, and it's just it's so heartbreaking. It's just, and they say, why does this keep happening? Why can't this stop? Why can't there be a standard mile per hour around every school? But it's up to, I think, the local jurisdictions if they want it to be 20 miles or 10 miles. And so there's no consistency, and 5 miles faster or slower, one of the trauma surgeons says, makes such a difference in the type of injury and the survival of a person.
And of course, there's engineering and enforcement, which
Yeah.
plays a big role, but we focus on education with our program.
But all three working together, I mean, that's.
Yeah.
I have a question. Do we know yet if there's any data around people who are on those motorized scooters and how that might affect pedestrian safety issues on Long Island?
I always wonder about that in New York City. You see them buzzing around everywhere.
They're the ones who should get congestion
Yes.
Oh my gosh.
pricing. They should be hit with something, but, you know, there are some laws.
There are some laws, they vary. I know Suffolk County, there was a code that was being drafted some months ago. I'm actually not sure where that is right now. But a lot of the regulations right now are kind of fuzzy, which is kind of a lot of the discussion that we've had with our
Yes.
NYCTS partners.
And I think they'll be talking about that at this, and we have been talking about it.
Actually, our scholarship contest this year revolves entirely around micromobility safety issues. Yes, so that is definitely a hot topic that we have been talking a lot about.
But it's so often, I gotta shut up now. Public health, right, healthcare, you see the cart always comes before the horse, so manufacturers produce these micromobility carts, or whatever you wanna call them, which are very convenient and helpful for a lot of people who don't drive, you know, that don't have a license, that are in the city and need to get around, without there being thought behind, well, how should we regulate this? And they just all of a sudden appeared on the streets and they were whizzing in and out and. Okay. But there's also a certain population that uses them too, and so is it fair to take that away from them and to restrict them, or to, I don't know, right, see, so then there becomes that whole ethical dilemma.
So we're not solving that problem, just educating people about it.
Yes.
But yes, definitely very much in our.
Yeah, so there is more and more coming out about that now, though, and some studies and whatnot, right? I know that's it, unless you have anything else to say, you know, there's some more food over there, if you wanna take something on your way out, please do. And that's it.
Well, I'm just gonna say that March is Colorectal Awareness Month, okay, even though it gets overshadowed by women, which is totally fair, it's fine. But still make sure you're getting your colonoscopies, your fit kits, your FOBT kits, try to stay away from FOBT kits, fit kit colonoscopies, sigmoidoscopies, okay, yeah, that's it, that's all I got.
Thank you.
And on that note, we will adjourn.
Thank you all.
Thank you all.
Thank you all for being here. Have a good day, everyone, on Zoom.